Good morning, everyone. Welcome to Gordon Day. This day was established in honor of Dr. Phil Gordon, who was the first director of colorectal surgery at the Jewish and at McGill. He was the founding president of the Canadian Society of Colon and Rectal Surgeons and was the only non-American to be the president of the American Society of Colon and Rectal Surgeons. His contributions to academic colorectal surgery are numerous, including co-authoring seminal colorectal textbooks, authoring seminal papers in peer-reviewed journals, known internationally, and known for his enthusiasm in colorectal surgery, which helped many of us decide what career paths to pursue, both on the local, national, and international level. To honor his esteemed reputation and his contribution to academic colorectal surgery, this lecture was initiated to help spread colorectal surgery amongst our group. And so we've had internationally renowned speakers in the past to speak. Today, we are very happy to have Dr. Phil Fleshner from Cedars Sinai in LA, Hospital of the Stars, although he likes to discount this. He is presently the chief of colorectal research at Cedars Sinai, and he holds the Shirley, Jessie Lynn, and Emmy Lynn Widjaja Chair of Colon and Rectal Surgery. He has numerous publications in peer-reviewed literature. His focus is IBD outcomes and randomized controlled trials to improve patient outcomes in IBD. His devotion to patient care and research was honored with the Sherman Prize in for Crohn's and colitis. Yesterday, we had an engaging day with him where he spent time with our residents, actually teaching them something, and they felt fulfilled for a change. Today, we hope, he's going to do the same with us, and he's going to speak about the evolution of the future of surgery in IBD.
Thank you, everyone. Good morning. Well, first of all, thanks for the invite. It's been an absolute pleasure. Phil, I remember meeting Dr. Gordon many, many times, and we had a lot of things in common. Obviously, we had colorectal surgery. We also, by the way, had the same first name, which was also, although he spelled it with one L, and I always said that was a better spelling than mine, but that's okay. And we also came actually from the same place, came from Montreal. So he was just a great guy. And again, thanks for it's been an absolute fantastic day and so far, and I really appreciate the invite. Pardon me. It's working? Here you go. Okay. These are my disclosures. So here's Fleshner's story. Okay. Born in that little city in the red called Montreal, which is where we are now. Believe it or not, I was born at the Ready Memorial, which apparently is no more. Apparently now it's a YMCA or something. I grew up in Côte Saint-Luc, not far from here. Went to Wager, which also is no more. And actually went to McGill undergrad for honors physiology. Um, this was me as a little boy. And actually found this picture. I was a cute little boy, obviously not like fine wine. I am not. I clearly have not got better with age. But that's the cute little kid, I guess. And um, this is my sag. I went to medical school at Einstein in New York City. I left the good old Canada. Then I did my general surgery residency in New York City. Then I went to Leahy for colorectal. And then I met my future wife, and we were training, and she was we met in New York and Boston. And I said to her, under no circumstances, I'm just telling you right now, am I ever, ever, ever moving to Los Angeles? Because who the hell would want to be in California? Anyways, I'm now at Cedars-Sinai, Los Angeles, and Medical Center in Los Angeles. And obviously, I've been there since. And let's talk about some of the evolving surgical concepts in IBD. I'm going to talk first about UC, and then I'm going to talk about Crohn's disease. So the first thing that you've probably read about is the transanal ileal pouch. Okay. We talked a little bit yesterday about this in teaching rounds with the residents, but the concept of what we're doing when we do ileal pouch surgery is to try to remove the entire rectum to the top of the anal canal. And it's very important to get low enough, because if you're not getting low enough in this scenario, you're actually not doing the patient a favor, because you're actually leaving diseased mucosa behind. And the textbook approach, or the schematic, is what you're basically seeing on the left, where you bring the pouch down basically to the top of the anal canal with a relatively short 1 to 2 centimeter cuff. And as shown on the right, that's usually not, unfortunately, what happens. And the reason it doesn't happen is, even though the black line, as you see on this schematic, is the optimal level of transection, it usually ends up being where the red line is in the real world. And that's because of the confines of the pelvis. And also what tends to happen is we don't really have a good stapler that is actually able to get way down in the pelvis, particularly in a thick male. So what you end up doing is shown even on the right, the extreme right graphic is a pointer here? No. Oh yeah, there's a pointer here. You can see the staple line here is actually jagged, and you end up with multiple staple lines, which is a problem because that increases leak rates. So not only are you actually setting yourself up in these using traditional, if you want, laparoscopic surgery, potentially for a leak because of all the staple lines, but you're also not really giving the patient a curative surgery. So this is where transanal surgery has sort of developed itself, a transanal pouch. And the concept is, instead of doing a top-down proctectomy as shown on the purple on the left, where you're coming down and then you're restricted by the confines of the bony pelvis, you're actually coming from the bottom up, which is relatively devoid of anything that's in your way. And you can basically go all the way in the pelvis, which leads to the transanal proctectomy, and then you bring the ileal pouch down. And the concept here is to try to get a much better transection of the ileal pouch. So these are the potential advantages of the transanal pouch. It's a shorter cuff. It's a single staple firing, which may reduce leaks. Easy access to the pelvis, obviously. And it probably maybe is a shorter operative time, but the problem is if it's going to be like that, you have to have a two-teamed approach, which sometimes is logistically difficult to do. And better cosmesis, because there's usually no incision that you have to do in these relatively young patients who like that. The problem we had with the transanal pouch are leaks. And we were really excited when this came out. This is our experience with now at least at this time, 76 transanal pouches that we did. And you can see in the green that our anastomotic leak rates were ridiculously high. I mean, they were at least 3 times higher. In fact, we were now approximating, like we talked a little bit yesterday about how the Europeans accept a 15% leak rate. We were actually approaching their leak rate, which to me is completely unacceptable. And we actually showed that even with the evolving, the sort of the learning curve, that the leaks still remained. And we also obviously found a significant difference in the length of stay. So because of the leaks, which obviously are devastating in these patients, that basically affects their overall quality of life, basically their entire life, we decided to abandon the procedure. And, we're thinking to ourselves, well, maybe we're the only ones that are getting these leaks. This is actually a study that was presented at IOBD. It's not published yet in any way, but this was a randomized trial looking at it's called whatever. It's a study that's actually based out of Toronto with Anthony DeBuck, now in Cleveland. And it's a randomized trial comparing transanal pouches and transabdominal pouches, the traditional way, if you want to call it, with laparoscopy, in terms of their functional results. This is just the Carefo score, which basically shows there's really no significant difference in function. So that at least is good. But look what they also found again. They also found this signal that the leak rates were ridiculously high. So it's not just us that are finding this, other people are finding this. So that's the reason we've essentially abandoned the transanal pouch. And I think a lot of us abandoned the transanal pouch also because robotics. Robotics has basically come in and allow us to get lower and lower in the pelvis, as opposed to what we can do with traditional laparoscopy. And this then has sort of led to the sort of abandonment of the transanal pouch. There are, however, some times that I still use it when you're doing a proctectomy with no anastomosis, okay? You're doing a completion proctectomy, you're doing, for example, an APR with an ankylostommy, you're doing a total proctocolectomy and ileostomy. I think those are very reasonable approaches to try to reduce scars. And obviously, there's no anastomosis. But again, a robot obviously is a reasonable alternative in that scenario as well. But I do occasionally do it still for highly selected patients who want ileal pouches. If they want it, if there's a difficult pelvic exposure, let's say they have huge fibroids. I'm anticipating a very fat male, which hopefully you're not going to operate electively anyways in that fat male and try to have him, for example, lose weight. Or if the patient say, look, I don't want any incision. I live in California, in Los Angeles. No one wants an incision, so they have to go to the beach and look sexy. So some people don't want incisions. So those are the potential patients that might still be eligible in my mind for transanal IPAs. Next concept. Talked a little bit yesterday. This is really an emerging concept of the therapeutic appendectomy. We've been taught all years during our general surgery residency, in particular, don't take out appendixes unnecessarily. We're all kind of, we don't want a negative appendectomy rate, but now we're trying to tell you should be taking out the appendix. What's going on here? So think about it for a minute. Here's this little organ sitting at the base of the appendix. We talked a little bit again yesterday about this, sitting in between a non-diseased terminal ileum and a crazy diseased, could be, if they have pancreatitis, cecum. And it's sitting right there. And we know that the appendix is rich in lymphoid in immune surveillance. So could it somehow or another, the appendix, therefore, be involved in dysregulated of the colon? It seems intuitive that it's doing something, but we don't know what it's doing. So the question is, how do we know that it's doing something? Well, our GI colleagues will tell you about this finding, which we see frequently, and not every once in a while. You're doing a patient who has, let's say, colitis, and they have left-sided disease, and the rest of the colon is normal, and then you see the cecal patch right around the AO, and you're saying, what the heck is this? Doesn't it sort of imply to you that maybe there's something going on with this appendix that's leading to this? So that's one sign that there's something going on. The other sign is that there's actually been some data on this, early data from Australia, for example. These were patients who had ulcerative proctitis, not colitis, okay? And what they did is they took 30 patients and they did an appendectomy on these patients, okay? And you can see from the data that 90% of the patients improved, okay? 40% had a complete clinical response off medications, okay? And they responded slowly, but they ended up responding. So it's not like there's someone like, let's just take the appendix and see what happens. So now we're starting to see signals that potentially the appendix is really doing something clinically, which then led to the two trials that has got a lot of press lately that we'll talk about. There are methodological problems with it, but I think it brings up interesting concepts that we're going to be seeing. So the first one is the ACCURE trial, excuse me, which is an open label. It's called a pragmatic RCT. Now, these were UC patients in remission, okay, who had been treated with a prolapse for 12, with a relapse within 12 months, okay? They were then randomly assigned to an appendectomy with continued maintenance therapy. So it's not like you're withdrawing therapy, or they would continue on the maintenance therapy alone. And the concept was, would the appendectomy reduce the ability of them getting a disease relapse, which was defined as total Mayo score greater than 5. If they did not have endoscopy, which is a big problem with this study, they were actually just using exacerbation of symptoms, the fecal calpro, or treatment intensification, which you can argue may not be such a great either entry criteria or, quite frankly, an endpoint. We'll talk about that in a minute, okay? But that was an interesting concept. And what did they find? You can see in the pink, patients who had an appendectomy had a significantly lower risk of clinical relapse than the patients who were kept on medical therapy. Okay? And you can see the Kaplan-Meier curve on the right showing a significant trend. This was a signal that the appendectomy was helping in terms of the disease course in these patients. But again, let's go back to it's like always the details are on the methods, okay? Patients and docs were unmasked. And in fact, the Mayo score, which was used as one of the primary endpoints, one of the components of the Mayo score is subjective. It's basically based on physician assessment. Guess what? Bias, okay? There were study modifications down the road. I mean, you can argue they changed the power in terms of the ends that they were done. They wanted to do that because of COVID and all types of stuff to try to get the study done. That obviously is potentially a problem. But they also used just a fecal calpro as an entry point to assess whether or not they were in remission at baseline. They did that because they couldn't scope people because of COVID, okay? 50% of the eligible patients who declined participate. This study took years and years to do. So you're wondering whether or not, in fact, they're taking the typical UC patient that we're actually talking about, who really would be a candidate for an appendectomy, okay? So there's a lot of problems with this study, and there's also no long-term data. This was 12-month data. There's been some data. There was an abstract that was presented at ECHO this earlier in the year, had a different endpoint. This was actually the initiation of advanced therapy, or the not use of advanced therapy, but you can clearly see that there's, again, some suggestion here that the patients that had an appendectomy were protected from that. But having said that, though, this was a different endpoint, not very robust long-term data. Okay. So that again is in a group that suggested there was still a signal, but in a patient who had a relatively mild UC. The next study that came out was the COSTA trial. Okay, that's the acronym. You can see a typical, nice acronym from what basically we're trying to do. This is a multi-center patient preference trial, which is sort of randomized, but it's not. But the patient has a decision whether or not they want to go into an appendectomy or they want to have a jack. Now, these were patients with medically refractory disease on biologics, different patient population that was in the ACURE trial. And they randomized those patients to an appendectomy, or they randomized them to the next line of therapy, which would be a jack. Okay. For example, I think it was tofacitinib, if I recall, in this study. Okay. This primary endpoint was a composite of three things. Okay. Total Mayo score, subjective. Remember that. Okay. No oral corticosteroids or a switch to another advanced therapy, and colectomy. So there were three components of this composite score that was used as their endpoint. Get back to this in a minute. Okay. This is the primary endpoint. Okay. Clinical remission at 12 months was significantly higher. So you look at this and you say, wow, look, it's fantastic. This is really working well. The patients who had the appendectomy in blue did markedly better than the patients who had the jack. But again, look back into what the primary, how they define that. Okay. One of them was, as I said, they had to have a Mayo score or an endoscopy score that was acceptable. Okay. Take a look at this. The endoscopy score looked like it was different, statistically different between the jack and the appendectomy. But the patients who actually were in the jack group didn't have to have a colonoscopy after because it was protocolized because it was only going to be based on clinical indication. So how do we know, in fact, that the jack patients really were actually doing well or not doing well? That's a big confounder. They actually admit that even in their limitations of the study. So that was one part of the endpoint. The other parts of the endpoint, which are the two graphs that I show you here, were both insignificant, not significant. So in fact, you look at the study and you say, aha, there's a difference here. But if you really go into the details, there may not be a study, a significant difference. So this is the critical analysis. The MDs and the patients were unmasked. The total Mayo score, in fact, as I mentioned before, includes a global physician assessment. Okay. There was actually also an entry, a lower steroid use in the appendectomy group. So the question was, were the jack patients potentially sicker coming in? And we have actually no long-term data on this. Okay. This is 12-month data. We have actually no long-term data. Okay. So how do you put these together? So it's suggesting that, in fact, it may have a role. Now, remember that when we're doing appendectomies, you should not be telling your patient, I'm doing an appendectomy, and you're never going to see the GI doc again. Okay, this is not withdrawal of therapy. This is an adjunct to their current therapy. It's just like another biologic or another advanced therapy, if you want to call it. Okay, the trial suggests an effect, but we need external validation. We need good long-term data. As I was discussing yesterday, I've done 14 now. You talk about real world experience. You always talk about real world evidence to try to reproduce what's done in randomized trials. My personal experience with 14 has been universally unsuccessful so far. So who knows? Okay, maybe I'm not doing the appendectomy right. I think I am. Okay. And the other thing that we don't have is any translational component. We have no idea what's going on. It would be very interesting in the future because we're talking about evolving future trends. It would be very interesting if we had a marker. For example, in the appendix, if we can do a colonoscopy, biopsy some marker and say, aha, you're the patient that's going to respond to the appendectomy and you're not. So that actually, it would be very intriguing to see 20 years from now if we're going to end up getting to that point. It's almost a form of personalized surgery, if you'd like. This will be the ultimate way to potentially do a patient with UC. The other thing I want to talk about, the evolving concept, is the advanced therapies and their surgical outcomes. This is the worst of the worst of the worst surgical literature. The literature that came out initially with advanced therapies at that time was mainly biologics, suggested that there was all these negative adverse side effects of biologics on healing. And therefore, we were making unnecessary leaks and we're doing ileostomies on patients and doing 3-stage pouches basically for no reason. It was all because there's somehow or another was some signal that at least at that time, the biologics were affecting surgical morbidity. And there were some animal models that actually suggested that. For example, these are the drug classes of advanced therapies and some animal model suggestion that there were some effects on, intestinal wound healing. Those are animal models. There were some clinical observations, but some of the data was discordant, but it was all retrospective, typical nonsense surgical data. Okay. So then there was a systematic review that was done last year, 28 garbage studies. When you put garbage into a systematic review, what do you get after? Garbage. Okay. Systematic reviews don't get rid of that problem. As much as you think that's in some way level one evidence, that's a lie. Okay. But what it showed is that anti-TNF therapy was not associated with an increased risk of postoperative complications. The evidence for veto and the other class of medications was very limited, and we have absolutely no data, no robust data, at least for TOFA so far. Okay, that's a jack. So what this suggests to us is that you basically may not. There's a signal here. That signal that we thought that these medications were affecting it were actually incorrect. Okay. So what did we do? We said, this is nonsense. So we were involved in a study where we did 17 multi-center prospective evaluation of over 900 patients who had of IBD. And we looked at whether or not, in fact, there was effect on TNF from surgical morbidity after. And you can see on the top, the TNF exposure group, whether or not they were exposed to it or not. You can see that you don't have to be a genius here to figure out that there was no difference in terms of any outcome whatsoever between the patients who had TNF exposure or not. And even based on the drug level showing the lower graph, there clearly was no signal. So this is the best data we have so far, prospective, that shows our concerns that we've had about these drugs are unfounded. It most likely is related to the patient themselves coming in and how malnourished they are and how anemic they are and how much weight loss they have. That's the thing that should be guiding whether or not you have therapy. I mean, so when you have an ileostomy, for example, or whether or not you should do a three-stage ileopyramidal anastomosis. So the other thing that it suggests, and I've been going around telling our gastroenterologists that, is that if your surgeon comes to you and says, well, the reason that the patient had a leak after is because of the medication you put them on, I actually tell our GI docs, BS. That's not the case. It may have been, quite frankly, because you held on to the patient too long, and now they're hypoalbuminemic and sick, but it has nothing to do, quite frankly, with the medication. That's not right. Okay, so your GI docs may come back and tell you that. Okay, we may not be able to use may not be able to, blame the drug for the adverse effect anymore. Okay, so that's UC. What about in Crohn's disease? Okay, new concept, mesentery-based surgery. What the heck is that? Okay, well, one thing is we're all taught in medical school that the mesentery, all it does is bring blood from the aorta to the bowel. That's all it was supposedly going to do, right? Maybe drain it back to the portal vein. That's all it really does. But we know that that's absolutely incorrect. It's more than just blood supply, lymphatic drainage, neural input. It's immunologically active. And if you think about Crohn's disease, there are two features are really landmark features of Crohn's disease that you never see in any other disease. Creeping fat, that's never seen anywhere. It's just, the sense of it starts on this, the disease starts on the mesentery and rolls up the abdominal and the circumference of the bowel. That's seen on nothing else. There must be something with the mesentery there. And the other thing that you think about is that Crohn's disease is not, as opposed to UC, is not a disease that starts circumferentially and is, we always think like UC starts at the anus and goes up continuously up various distances, but it's also not only longitudinally continuous, but it's also circumferentially. Crohn's is not. Crohn's is discontinuous, but it's also discontinuous in a circular fashion, tangentially, if you want to call it, and it starts on the mesenteric surface. That's why, by the way, we're able to do strictureplasties, because the strictureplasty is left relatively unaffected on the antimesenteric border. That's why we can do a strictureplasty in Crohn's, but we can't do a strictureplasty in a patient who develops a stricture after like an ileoclonic anastomosis. That's its circumferential. Okay. So aside from that, so there's something going on with this mesentery that's suggesting that it is. So what are some of the things that sort of led us to believe that in fact this may or may not be important? Well, if the mesentery is really involved, maybe we should be taking wide mesenteric dissections, just like we do, and we do surgical oncology. We take big, huge lymph nodes for lymph node clearance and cancers. Okay, we do it all the time. We feel comfortable. This was Calvin's coffee study. He's a colorectal surgery in Limerick in Ireland. And basically what he did is he published a study on a series of patients about, I don't know, 8, 9 years ago. And what he did is you can see the differences between A and B. A is the traditional way that we manage Crohn's, relatively close to the bowel. B is when we go wider, and just like we did with a cancer clearance operation, basically to the root of the mesentery, just like we take all our lymph nodes, right? And he showed in this data, small patient numbers, ridiculous, quite frankly, poor science, poor studies. That look at the bottom. You can see the surgical recurrence rate. Excuse me, when they had a close mesenteric dissection, which is traditional, was 40% versus a wide mesenteric dissection, almost none. So this was like a signal that maybe was something on. It's bad signs because patients were kept on different medications after. So there's a huge number of confounders. So what did that lead to? Randomized trials, thankfully. Okay. The first trial that we had is the so-called spicy trial that was mainly based out of Northern Europe. And again, you can look at mesenteric sparing versus in the blue versus the extended one, which is sort of the way we do for surgery. And you can see, again, the blues and the greens. Again, you don't have to be a scientist to figure out that the blues and the greens are pretty much equal. There's absolutely no difference based on any endpoint of them. We use the modified Rutgers classification because that's a very good assessment of what the patient's going to do down the line. Okay. And now comes up the mesocolic trial. The mesocolic trial was a Chinese trial, okay, in China, okay. Their primary end, this was published just a month ago, by the way, just so you know, so I'll bring you up to date on that. Their primary endpoint was surgical recurrence. Now, there was no difference. That's a primary endpoint. But if you look at their secondary outcomes, this is a like a mod like what they looked at endoscopic rates based on Rutgers score, like a medium endoscopic recurrence greater than I2B, which is sort of considered a medium approach, versus the severe endoscopic recurrence in I3 and I4. You can see clear-cut differences between in favor of an extended mesenteric resection in red versus the limited mesenteric resection in blue. Okay, so this suggests that there's a signal going on here that maybe we should be doing this. So, what do we know about this? Well, let's talk about it. The problem with the mesocolic trial, okay, is that there was a central reading only of endoscopy reports and photographs. Okay. Now, you think about if you're an endoscopist, if you're doing an endoscopist and you're looking at anastomosis, okay, you're going to probably take one picture that you're going to send, but how do you know really what's going on around? Okay, maybe you forgot, maybe there was an ulcer that you forgot to take a picture of. Maybe you were kind of, because you were biased as to whether or not the patient had a mesenteric because you knew it. Basically, maybe I did not going to send him the bad picture. So therefore, you should have sent video clips, which is actually what was done in the spicy trial. Those were done by independent assessors. Okay. They also had different anastomotic techniques. The spicy trial had it standardized with a side-to-side anastomosis versus the mesocolic trial where there was not standardized. They had end-to-side, side-to-side, isoperistaltic, antiperistaltic, all that kind of, there was no thing. And they also had a difference in terms of where, we talked a little bit about this yesterday, the extent of the mesenteric dissection. Why is that important? In the spicy trial shown on left, in the black is what they took out. I'm sorry, those are the vessels, but you can see where the red line is in the middle. They just removed the mesentery in between. Okay. So they left those vessels behind, as opposed to the mesocolic trial, where they went almost essentially to the SMA origin with the ileocolic artery. They did a complete dissection of the vasculature. We showed some data yesterday that might have a difference in terms of where the immune cells are. So maybe that's a difference. So we don't know. So we don't know where this is going to be going. It requires external validation, but I'm going to bet my bottom dollar that there's going to be a role in the future for extended mesenteric dissection in Crohn's disease. It's a very interesting observation, but we're all used to doing it. The problem is we have Crohn's patients, as you know, who have mesenteries the size of your fist that can go all the way down to the root of the mesentery. And I think a lot of us would be a little concerned about taking that down, not only because of bleeding, but also you're potentially going to knock off blood vessels that you don't and start extending your resection in a patient with Crohn's where you want to practice bowel economy because you don't want them to keep getting resections, right? You want to practice. We've always taught to try to practice bowel economy as best we can. So it'll be interesting to see where that's going. So if the mesentery now is so important based on what I just talked about, let's go look at the Kono S. This is the new thing. Kono was a Japanese surgeon. S is just so that you know, is for the so-called supporting column. That's why it's called Kono S. And it's a fancy anastomosis. Here, the mesentery shown on the left is preserved. But hold on, it's preserved. And then you end up making a supporting column shown in caption C. You basically sew the ends together underneath. And then you do an anastomosis on top. So what you're basically doing, as shown on the right, is you have an anastomosis hand sewn on top of the supporting column, but the mesentery is excluded. Okay. So the question is, can this give us some clue as to whether or not, in fact, the mesentery is important? Okay. So this is the first trial that came out, randomized. Actually, finally, some relatively good science in this. Okay. This was an Italian study. And you can see in the bottom three columns there that there was a signal here that the patients who had the Kono did much better in terms of endoscopic recurrence and in terms of clinical recurrence versus the patients who had a standard side-to-side anastomosis without a Kono S. Okay, so that's starting to suggest that maybe there's something, small patient numbers. So what had happened? Bigger trial, large numbers of patients. Okay, again, you don't have to be a scientist to figure out this is a negative trial. So we don't know where this is coming from. We don't know what the difference is. We think that a lot of it is based on the interpretation of the way the Italians did their assessment of the endoscopy. Some of the people who were involved in that study suggested, Flesh, you have no idea that was done. I think you can kind of understand that happened. So maybe there was some stuff going on in there that we can't read between the lines. But this was actually a really nice study, large patient numbers. Now, granted, it's only 12-month recurrence. It'll be interesting to see what's going to happen down the line. But I think this signal suggests to me at least that the CONOS is telling us that the mesentery is not important. It also suggests to us, quite frankly, that you probably shouldn't be doing CONOSs. As much as we like to do it, they're actually cool operations. You probably should not be doing a CONOS. And again, let's go back to the third concept of why the mesentery might be important or not important. This is strictureplasty. We talked about this before, okay? Strictureplasty, very, very common in Crohn's disease. If you can see in the figure, you can also see the creeping fat. See the creeping fat? Almost always when you have stricture, you'll have creeping fat, okay? So this is the way this is the way a strictureplasty is made. You do an antimesenteric enterotomy, then close it. You make it longitudinally, and then close it transversely, but you're not touching the mesentery, okay? And what happens to the disease of that strictureplasty? It almost never comes back. You can see 7%, for example, of these patients who had a strictureplasty, it recurred at the strictureplasty site, okay, versus opposed to other sites at 18%, okay? But you're not touching the mesentery. So if the mesentery is so important, why is it not coming back? So this suggests to you, in fact, that the mesentery is not important. This is some old data that tried to look at some translational side to this. What they did is they looked at the stricture 3 months after operation, comparing some there's some interleukin, some cytokine expression, and you can see there was a difference at 3 months. But that probably is just related to the surgical site itself. But if you look at 12 months after, they were Cone Stone negative because all of the inflammation had gone down. There's no evidence of any recurrent disease. You did not touch the mesentery, and yet the disease is gone. So that implies that the mesentery is not important. So you can see we don't know where this is going right now. It's very, very controversial in terms of whether or not this in fact is important. It's intriguing because there's no question that the mesentery is playing a role in the pathogenesis of the disease. All right. By the way, just so that you know, there are other studies that are being done. You're going to start hearing about these. There's a so-called MERCAT study. This is a Northern Europe study, mainly based in England. This is actually going to be combining the CONOS concept with the extended mesenteric dissection to 4 arms, okay? There's going to be a translational component, thankfully, using flow cytometry, so it'll start maybe get some sense of what's going on biologically. And this is going to there's another study called the EXCEED trial, which is going to be a blinded randomized trial that's going to basically be almost replicating what the mesocolic trial did. So we have more data. We're going to be having more data come up. We're waiting the results of these trials. The way you should think about it right now as a clinician is that, yes, there's a signal that the mesentery might be playing a role. I don't think you have to start going wide on mesenteric dissections right now. You may want to practice it, but I think most of us know it just from our cancer experience. All right, what about ileal pouch surgery for Crohn's disease? My goodness, really? Okay, so look at the textbooks, what they tell you. These are the so-called real big textbooks, at least in the US that we use. Look at some of the things they say. The last bullet is the best. The creation of an ileal pouch is contraindicated in a patient with a preoperative diagnosis of Crohn's disease. If you're on a board exam, by the way, for the colorectal fellows, or maybe even from the Gen Surg people, you should say you should never do that for a board exam, okay? Because if they do that, they'll think you're crazy, okay? But is there really a role? It's like anything else. What are we really doing in the real world? And this is the rationale for not doing it. You get recurrent disease in Crohn's. You have anal disease. You shouldn't be doing pouches. There's transmural. The disease may involve the small bowel. There's all types of reasons why you should not be considering doing pouches in Crohn's disease. But actually, I've been doing them. And the reason I've been doing them is the following scenario. You have a young woman, for example, who has colonic and rectal disease and Crohn's disease. No fistulas, okay? And they go to surgeon A, and surgeon A is, look, they become medically refractory. Surgeon A said, I need ileostomy. I'm 21 years old. I got better things to do. Dr. Fleshner, do I have an option? I said, well, you might consider a J-pouch. I said, J-pouch, what's that? He says, well, you might end up with an ileostomy here. I mean, like, you're going to end up with an ileostomy in the operation that doc's given you. But what's a J-pouch? Well, it's a temporary one. So what's my long-term results? He says, we'll talk about that in a minute. But basically, the vast majority of the patients do not end up in an ileostomy. Get back to that patient in a minute, okay? So we've done this is a relatively old study now, but we've done now about 70 of these, okay? And what you can see is, this is at least our experience that we published in DCR of 46 of them. You could see about half of them, 24, ended up with recurrent Crohn's disease. And these, by the way, these were not like, Crohn's disease, like, was it UC, was it Crohn's? You could see in the first column, a third of them had small bowel disease. Okay. A third of them, more than a third, had perianal disease. They had discontinuous inflammation. And a relatively robust follow-up after showed that about half of them ended up with recurrent Crohn's. So you're saying, my goodness, half of them end up with recurrent inflammation. That's terrible. But look at the Kaplan-Meier curve of what happens to them. The blue shows, I'm sorry, the red shows the incidence of getting inflammation. But look at the blue. The blue is pouch failure, ileostomy. And the reason is that there's a discordance between those two is advanced therapies. These patients get put on medication after the provincial diagnosis or even before, and the advanced therapies are helping them stay away from an ileostomy. So that patient that I talked about said, so I understand I'm going to get inflammation back in maybe half of the time, but I can go on a biologic therapy, and if worse comes to worse, I can have an ileostomy that the other surgeon down the street said I can have. Sign me up. I can understand why a patient would do that. So that's the rationale potentially for using J pouches in patients with Crohn's disease. Now, again, this is the way it used to be thought. Okay. We used to be thinking that clearly was on the side of doing an endoleostomy in these patients, no pouchitis, relatively good results with endoleostomies, and no permanent stoma that you'd have an IPA. That did not basically lead to a better favorable result. But because of advanced therapies now, I think the bar has changed. I think it's now weighted down to consider ileo pouches inserted. Now, again, don't go around, thinking this is for everyone. You have to have highly motivated Crohn's patients that are willing to avoid a permanent stoma. They have to be taught, or at least advised, that they may end up with a significant chance of inflammation. They may end up with a fistula. They may end up with pouch failure, but they may end up also with a lifetime exposure to advanced therapies, which has its own inherent risk and cost. Okay. And again, one of the things we're thinking about, and we've done some of this now, is, patients have ileocolic resections. The vast majority of those patients are put on pouch prophylaxis, and medication prophylaxis. Why don't we do it here? And we have some data to show that the patients who are put on pouch prophylaxis at the time of their J pouch actually have a lower incidence of recurrent Crohn's. So just like you would for an ileocolic resection example. Okay, evolving concepts. Another one, early surgery for luminal disease. Okay. All right, so let's go through. We talked a little bit about this yesterday. Just so that everyone knows, first reported not in 1932, okay, the Sinai Hospital. The primary therapy, just so that you know, at that point was surgical excision, okay? But what happened is it solely didn't go that. It went to a secondary role for surgery because there was no medication at the time. There was concerns over short bowel and the recognition for the need for repeat surgery. So this is the way I was taught. CD is not curable with surgery. The disease recurrence is common. Surgery is invasive and complications are uncommon.
Thank you. Morning.
That was in the time of hi whoever said hello. And
Is the next one for you? What's that? Yeah, perfect. Is that he's a right? He's a right. Yeah, perfect.
Dr. Tanzer, can you mute your video, please?
Yeah.
Okay. And don't operate unless absolutely necessary. Surgery is the end of the road for Crohn's disease. Okay, so comes along the Lyric trial, which maybe some of you have heard of. It's also a Northern European trial. What they did is they randomized patients who were refractory to infliximab and had biologic therapy. Okay, they randomized, I'm sorry, to conventional therapy, excuse me. To steroids. They then randomized them to either an ileocolic resection or they randomized them now to infliximab medication. And what their primary endpoint was quality of life. That's what they used. We talked yesterday. The reason they chose quality of life as a recurrence is that it was a quick thing to do, as opposed to waiting for the patient to get 12 years down the line to see if they got a recurrence. That's kind of the study they didn't want to do. So they used quality of life. And what you can see here, there were some differences. There was maybe a little bit of improvement in one of the domains in terms of blue showing a better quality of life. Those are the patients, who had the ileocolic resection. But there was also some studies that they actually did showing costs. When I was a surgical resident and young tending, the cost of ileal surgery of Crohn's disease was driven by us because all they had at that time were steroids and 6-MP. Now that's a 180-degree switch. This is being driven all by biologics and advanced therapies. A dose of infliximab, for example, in the United States is about $7,000. One dose, $7,000. That's a lot of, at least in my experience, a lot of colectomies or ileocolic's you have to do to get that one patient. So they clearly showed a cost advantage. But the thing that it also showed, okay, in subsequent follow-up is this, okay? After a median follow-up of 14 years, and the patients who were randomized to the surgical group, less than 20% required additional surgery. About a quarter of them were on the anti-TNF. 60% had never required any further therapy, okay? More than a half were medication-free, surgery-free. But if you look at the biologic group, the patients who were randomized to infliximab, two-thirds of them went on to require surgery, and the remainder obviously continued on the medical therapy, on the anti-TNF therapy. So what does this mean to you? Is it possible that we can actually now operate on these patients, okay, and more than half of the time make them medication-free and surgery-free after a median follow-up of 14 years? That's very provocative, okay? So maybe somehow or another what we're doing by operating on these patients is we're resetting the immune system in some way, taking out this disease before it becomes a problem. Intriguing. But there's other reasons to consider early surgery, okay? One of which is that as you progress on, because almost all of these patients start as a B1 phenotype, a relatively inflammatory phenotype, which is what the Lyric trial included, okay? They didn't include patients who had more advanced disease. As they then progress onto B2 disease and onto B3 disease with either strictures or abscesses, the ability of us to perform a laparoscopic resection goes down. The surgery becomes more complicated, more stomas, okay? And these young patients who otherwise would love to have a relatively straightforward ileocolic resection, laparoscopic ileocolic resection, which is what Lyric did. So I think that's a good thing. Clearly lower costs, I showed you. Better quality of life, you could argue, is pretty much the same. I think one of the biggest reasons why this should be considered is kind of a nebulous one, but an important one from a patient point of view, is this concept of patient empowerment. Instead of them, the patient, watching the disease take them, they're saying, you know what, I'm going to take you on. And this is the way I'm going to take you on. I'm going to do it. I'm going to be proactive, okay? I'm going to operate on it. I'm going to get it out. And I think that's a very, very important concept to tell patients. And they like to hear that because otherwise they seem, which you can obviously understand, they seem sort of helpless watching a disease kind of affect many of these patients in the prime of their life. Okay. Finally, early surgery for perianal disease. My goodness, really? Okay, so this is a paper that came out about 50 years ago now. John Alexander Williams was a British surgeon. This guy wrote this paper in DCR, okay? And this statement that I'm showing in yellow put back colorectal surgery of the anus in Crohn's disease years and years and years, okay? In our opinion, fecal incontinence, which is one of the big problems that we have in dealing with patients with Crohn's disease, is not the result of the disease, but the result of us, what we're doing surgically in terms of fistulas. So what they're basically led to this concept of almost surgical nihilism, okay? So the concept was, we can't fix it. All we're going to end up doing is making the patient incontinent. Why are we doing this? And that led to the concept, at least what I was taught in my residency, and I think is still maybe pervasive now. You put a ceton in, sayonara, go see the GI doc. I can't fix you. And there's this concept of surgical nihilism that says, well, I can't do anything for you. But is that really true? Okay. So this is what tends to happen in the real world, okay? You have a patient who has an abscess fistula, you put a ceton in, they get better, they're put on advanced therapies, they come see you, the ceton's in place, they feel great, okay? They go to the GI doc. The GI doc, usually what they say is they say, all right, I'm going to give 2 doses of my advanced therapy and I'm going to pull the ceton because they think they can heal the fistulas, okay? So if you look, that ceton in the middle, there's various ways you can go there. You can continue the advanced therapies. You can do definitive surgery. You can just pull the ceton in. You can continue the advanced therapies. There's 6 different ways that you can manage the patient who's looking at you as a surgeon. Can I do anything surgically? Obviously, you're not going to do a 6-way randomized trial. You can't do that in perianal disease. But there's actually been randomized data to basically address what the GI docs are traditionally doing. What they're doing is they're pulling the ceton and they're continuing the patient on medical therapy versus what we'd be doing if the patient had a relatively easy surgically corrected fistula that you're not going to make the patient incontinent, a lift, a flap, okay? Can we as surgeons do that? So you can look at the 2 bars in the red, the box in the upper left of the slide is what we do. The bar in the lower right is what the medical docs do. There's a comparative prospective randomized trial about this. This is called the PISA 2 trial. And the PISA 2 trial was really informative because what it showed was, even though the clinical healing shown on the Kaplan-Meier curve was basically comparable, the MRI healing was significantly better in patients who had surgery versus those that had the medical therapies. You're saying, well, who cares? The clinical thing didn't show a difference. But the reason for that is that when you assess a patient in studies, when they're looking at clinical healing, they're pushing on the fistula tract on the open at the scene. They're seeing if it's open, if there's any drainage. You have no idea what's going on behind that fistula, all the way to the anal canal. Okay. And that's the reason why many of the patients, that is a poor surrogate of healing. But MRI is a great surrogate of healing. Now, remember the concept that the PISA 2 trial with surgery showed that MRI healing is better. These were two studies, two separate studies that showed that when you have deep remission healing on an MRI, which is what the PISA 2 trial showed, the ultimate remission rate of those patients were significantly better than the patients who did not have that. These were fibrosis, no question, no enhancing on a T2 image. This is like literally these patients had sealed the fistula. And that's exactly what we did and exactly what the surgeon did. So we actually showed in that study that we can get long-term robust healing by operating on that patient as opposed to just keeping the patient on medical therapy. Okay. So that was actually very provocative. This is our study. Like, again, we always talk about real world evidence. This is our study. We looked at our 140 patients, and we actually found the same thing. We compared the patients who are non-randomized, this is a real world study, to medical therapy they were either given infliximab or adalimumab, and surgical therapy, which most commonly was a lift or actually even a fistulotomy in some patients. And you can see, basically paralleled exactly what PISA 2 trial. The clinical healing rates were the same, but look at the MRI healing rates. Again, significantly advantaged for surgical treatment. So don't be a surgical nihilist when it comes to perianal disease in this, okay? You should be thinking of primarily fixing it, but do not, and this is the concern, this is the big asterisk on the top, do not be overly aggressive and make that patient incontinent. So that's the reason why I sort of go around the country saying it's okay to do this, but I don't want this being done in anyone's hands. Like, nothing against general surgery. I don't want general surgeons to be able to do, because they're going to end up doing fistulotomies that I think most colorectal surgeons probably would not do, and making patients incontinent. So you've got to be with that big, huge asterisk on the top that make sure that you're not making your patient incontinent. Okay. So this is a summary. Okay. I'll stop here. Ulcerative colitis, few indications right now for transanal pouches. Appendectomy is intriguing, but we're waiting real-world evidence to see if it really does anything. Pre-op advanced therapy, no significant effect on surgical outcomes. You cannot blame your GI docs anymore for your screw up, or whatever you want to call it, for your complication. Okay. Crohn's disease, mesenteric-based surgery or weights validation, although it's very intriguing. Corn-OS at this point, as far as I'm concerned, is dead in the water. Okay, although it'll be interesting to see what long-term data shows. Ileal pouch for Crohn's disease, absolutely, in select CD patients. And you'll notice I use the word timely surgery. We don't use the word aggressive because patients don't like that. Some people use the word early surgery. I like it's timely because it's sort of like gentle, okay? Timely surgery for patients who have both luminal disease and potentially if they have perianal disease. Don't just sit around like a surgical nihilist and let the disease manage the patient. We as surgeons should be intervening just like we do in other diseases. Thank you.
Thank you for a great talk. Very interesting. And again, you managed to teach us a lot. Anyone have any questions?
That's I'm trying to check the chat. Here we go.
Okay. No. I don't see any questions.
I have one question for Dr. Fleshner. Can you comment on the role of mesenchymal stem cells in perianal Crohn's disease? We chatted a bit about it yesterday. Where do you see that going? And
yeah, so the question was, just for everyone in the virtual world, the question was, where are we now with mesenchymic stem cells for anal fistulas and Crohn's disease? The initial studies they were done in Europe, again, so-called ADMIRE-1 trial, which was a positive trial. Unfortunately, the ADMIRE-2 trial, which was based in the US mainly, was a negative trial. So the product, which had been approved in Europe, it was called Alphasil, okay, was actually taken off the market. It is nowhere to be found, okay? There is, however, also a trial that we just finished called the STOMP trial, STOMP, that's usually these similar type of cells, although this is from the patient themselves, onto a fistula plug. Now, many of us have used a fistula plug in the past. We found it I found it ridiculously unsuccessful. Okay. But what this study did is the concept is that you put the plug in and acts as a scaffold now for the mesenchymal stem cells to be to work with. Okay. And that actually showed an effect. In fact, the STOMP trial suggested it was a positive trial. The problem is the control group was not a good control group. It still showed about 40% success rate, which is basically what you're getting with just curetting it and basically putting in a stitch. So right now, dead in the water. I think what's happening now in the future, people are going to start using PRP a little bit more. I've had some experience with that with kind of limited success. The other new thing on the market is going to probably be exosomes, which is the active product of that's the way, just so that you know, stem cells, the way that they induce their biologic effect are through exosomes. So there may be some exosomal therapy that's going to be the new thing on the market. But right now, it's kind of not, we can't even get, first of all, you can't even get the product in terms of mesenchymal stem cells.
Dr. Chervenkov, you have a question.
Yeah, I really enjoyed your talk. I'm a transplant surgeon, so I'm going to come from maybe a different angle. Am I to understand that mesenteric removal of lymph nodes actually impacts on Crohn's disease and recurrence? Is that
Yeah,
what I
yeah,
thought?
yeah. That's the mesentery, like I was trying, I don't know if you heard that part of the talk. The mesentery is immunologically active. It's not just like I said before, of a conduit for vessels and nerves and lymph nodes. It's not that. It literally is immunologically active. We've actually shown very good data, for example, that creeping fat is a immunologic reaction to what's going on within the abdomen I'm sorry, in the luminal surface to bacteria. So yes, there's very good evidence that the adipose tissue is involved in the pathogenesis of the disease. For example, like I said, creeping fat. I guarantee there's no operation that you've done, Doc, as a transplant surgeon that you've seen creeping fat. Maybe it had IBD or Crohn's disease, but you're never going to see creeping fat in any of your intestine. I guarantee you. You're seeing that then the patient has IBD undiagnosed.
Yeah.
So there's
I'm
something
come
very
more
unique.
from, yeah, sorry.
No, I'm saying I don't mean to interrupt you, but there's something very unique about this immunologic organ that we used to think was just doing nothing. That's actually doing a lot.
I ventured to suggest that maybe there's tertiary lymphoid tissues in some of these lymphatic or lymph nodes,
There,
which is very similar to what we do sometimes, which is splenectomy to salvage a antibody-mediated rejection. And so there's probably a lot of similarities in that. And I would suggest you're probably performing removal of these very nasty tertiary lymphoid structures. And I would suggest somebody look into that and see if that is what you're indeed doing. A little bit more at the basic science,
no, honestly,
histological immunostaining area.
I mean, we have some data that shows that it's actually the immune cells along the vessel that actually is the problem. I don't recall in our data or anywhere else that anyone's looked specifically at the lymph node itself or the tertiary lymph channels. I don't know the answer to that. What an
Yeah,
interesting
because
observation.
they're in kidney transplants. These structures, these are tertiary lymphoid, basically reproducing a mini spleen
Right.
in the kidney itself, and it's organized along Th17 cells, B cells, and T follicular lymphocytes, which are all part of immune antibody mediated rejection. So I would suggest there's probably some similarities. Crohn's being an autoimmune disease.
That's interesting. Thanks, Doc. Thanks for that insight. Appreciate it.
There's a question in the chat wanting to know how you manage the distal rectal stump in patients with colitis who still have, hold on, who still have rectal disease and are awaiting a pouch.
Yeah, I mean, we talked a little bit about that yesterday. I mean, most of the time I just transect the rectum as a Hartmann procedure at the recto-sigmoid junction without violation of the superior rectal artery in the presacral space. Even though they have rectal inflammation, I think the suggestion that you're trying to say is, well, how about the inflammation in the rectum? Is that going to continue? It doesn't in the vast majority of the patients. Why? Because this disease, just like Crohn's, most likely is in an interaction between your immune system and bacteria. So once you fecal divert this patient and there's no more intestinal contents going through that rectal stump, the inflammation almost always disappears. Does it continue in some patients? Yes, but the majority of the time it doesn't. But it could also be, by the way, provocatively, what if I told you because we're taking the appendix out? Maybe that's why the rectum goes away. So I've thought about that. Maybe somehow or another we're doing our appendectomy. We're actually doing a study now looking at features of the appendix and whatnot to predict whether or not patients had recurrent proctitis after TACs. Maybe there's something in the appendix that can tell us about that. So that's another provocative. It has nothing to do with the colon, it has to do with the appendix or the fecal stream. So yeah, but that's the answer to your question, sir. Or where we give that, sorry.
That would otherwise be a radical appendectomy.
Yes. Oh, yes, exactly.
So I don't see any other hands up and I don't see any other questions in the chat. So again, I want to thank you for an amazing talk and for an amazing stay with us. We
Thank you.
thoroughly
My pleasure.
enjoyed it.
My pleasure, guys.